in good health.
Yes, sir.
So today I'll be talking about. Can you see the screen now?
Yes, sir.
Okay. So today I'll be talking about X-rays, mainly pertaining to surgery, which will be asked in your exam. A few brief point about when you are reading X-ray, or a few introduction about the X-ray is whenever you see X-ray, there are certain things which you are supposed to know. For in the sense is that when you see whichever X-ray you see, there is a white and a black, and in between white and black. So you need to know what is white, what is black. So black is always is a low density. It is depends on the density of the things. So black represents the low density areas, and white represents the white high density areas. So air comes as the lowest density, and bone comes in the highest density. So whatever white you see is towards the bone, and whatever complete black you see is air. So whenever you are given an X-ray in the exam, what are expected from a student is you describe the X-ray, the probable causes, and how will the patient present with those causes, and how will you manage the case. So basically whenever you see an X-ray, the problem with us is directly we think about the diagnosis. Okay, so for example, you see this X-ray, so never go directly to the diagnosis. Don't search for the diagnosis first. Search for the first with the bony thing, then with the lungs. Whenever you are given a chest X-ray, let's say for example, see for the bones, the rib, the clavicle, if the scapula, if it is visible, see about the scapula. Then go into the lungs from apical to the down up to the diaphragm, then come back, see the other side of the lungs and the mediastinum. Okay, so if you go follow an order, then it is very difficult that you will miss something. So don't jump into the thinking about the diagnosis first. Look at the X-ray, and then most of the X-ray will have name and what view, everything would be written in the down. Okay, see here you can see this is written L, means this is the left side, this is the right side. Okay, so this X-ray how you will read is, sorry, the X-ray, this is an X-ray of chest EA view. Okay, so you will see, is there anything? This is the first rib, this is the second rib, this is the third rib, this is fourth. Okay, this is the fifth, sixth, seventh. So ribs are okay, fine. This side also you will see ribs are okay, fine. Then you go to the lungs. Lungs, you just go from apical to up to the diaphragm. So vascularity is okay, lungs are okay. This is called the costophrenic angle. This is the cardiophrenic angle. This is cardiophrenic angle. Then this is costophrenic angle. All are okay. Okay. So what you see here, the white structure, can you make out the arrow? Can you see the arrow?
Yes, sir.
Okay, so the white line, what you see is the diaphragm. Okay, so similarly, this is the right dome of the diaphragm. This is the left dome of the diaphragm. So below the diaphragm, what you see is a black area. So whenever you see a black area, that is the air there. Okay, and basically in the abdomen near the diaphragm you will only see one air level, that is only the fundus in the left side, which is normal. Okay, but right side you will never see air under the diaphragm. Okay, you can you make out the air under the diaphragm in the right side?
Yes, sir.
Even in the left side, when you see, this is an outline of the stomach, so air is in the stomach. Even between the stomach and the diaphragm you can see there is air. Okay, so this is a case of a this is an x-ray chest a view showing air under the diaphragm. So now comes is whenever there is air under the diaphragm, uh, that suggests a hollow viscous perforation. It can be either a gastric perforation, a duodenal perforation, or any appendicular perforation, ileal perforation, sigmoid perforation. Any hollow viscous in the abdomen can give rise to air under the diaphragm, because when the patient is upright in a erect posture, the X-ray is being taken, so air tends to move up. So you will see air under the diaphragm, which is not normal in a normal individual. So most common cause of air under the diaphragm is duodenal perforation. Other causes can be appendicular perforation or a sigmoid perforation, any hollow viscous perforation. Then you have, when you do a laparotomy, after that if you take a X-ray, that is post laparotomy, you will see air under the diaphragm. You do a laparoscopy, post laparoscopy, you take an X-ray, there will be air under the diaphragm. And in gynecology they do tubal patency, that is Rubin's insufflation test. So in those cases also you will get a air under the diaphragm. So because the most common cause is a duodenal perforation, so you will talk about the duodenal perforation. Most commonly you will be asked what are the signs and symptoms the patient will present with. So a duodenal perforation patient will present with pain abdomen, okay, then vomiting, and the symptoms, the signs would be there will be board-like rigidity in the abdomen. The patient might be in sepsis, so tachycardia, tachypnea, and dehydration would be there. So skin turgor will be lost. Okay, the urine output may be decreased. Okay, so all these things the patient will present with. So diagnosis, mostly it is a surgical emergency, and the X-ray gives you a 80 to 90% probability of a air under the diaphragm if you are taking a erect posture X-ray. You can do it in supine also, but most better is a erect posture X-ray where you will get a air under the diaphragm. So now you might be asked about the management. So any hollow viscous perforation, the management is surgical. So before doing a surgery, what you will do is prepare the patient for the surgery. So optimize the patient pre-operatively and then do the surgery. So you will do all the investigations for anesthetic point of view, and then give IV fluids, antibiotics, analgesics, and if required put a Ryle's tube, aspirate. And then what is the treatment of the duodenal perforation is you repair the duodenal perforation with a omental patch, that is called Graham's patch. Okay, so that is about duodenal perforation. Now coming to another chest X-ray, what you see here is, first of all, similarly you will scan one by one ribs. Okay, ribs are okay. Then you will scan the lungs. Okay, so what you see in the lungs here is there is a collapsed lung marking here. Can you appreciate the collapsed lung marking on the right side?
Yes, sir.
Okay, so this is the collapsed lung markings, and the arrow which is pointing you can see air bronchogram in the left side, but you don't see any air bronchogram on the right side. And then, sorry, and then what you see is the mediastinum is little bit shifted. See, the trachea is not in the midline, it is shifted towards the left side. Okay, and then mediastinum is also shifted mildly towards the left side. So this is an X-ray showing pneumothorax. So then you will be asked about pneumothorax. What are the causes of the pneumothorax? Most commonly it is traumatic or iatrogenic. It can occur also in cases of COPD patients with emphysematous bullae rupturing. Okay, you did not see any fracture here, so most likely this is not a traumatic. Either it is a iatrogenic or a COPD patient with bullae rupture. Okay, so when you see pneumothorax, what is the treatment of the pneumothorax? Is you will put a intercostal drainage tube. So intercostal drainage tube is put basically in the fourth or the fifth intercostal space on the same side, on the right side. Okay, we'll put an intercostal drainage tube that is connected to a the sealed tube, so the air will go in and out from the intercostal drainage tube. Okay, can you appreciate the pneumothorax?
Yes, sir.
Yes, sir.
So now coming to another X-ray. This is an X-ray. You can see the bony fusion has not yet occurred. So this is a X-ray of a child or an infant. Okay. So in an X-ray of a child and an infant, what you see is the chest. You can see the abdomen, the whole abdomen. Also, you can see what is abnormal here is in the abdomen. What you see is normally what you see is only gastric shadow. Okay, here what you see is the gastric shadow is also there, and then another shadow is there, which is abnormal. So two air shadows you can see in the abdomen, that is called double bubble sign. Okay, so that means air in the stomach and air in the duodenum, and there is a obstruction. So it is a case of a duodenal obstruction. Okay, so duodenal obstruction can be intrinsic and extrinsic. Intrinsic means inside the duodenum, extrinsic means some cause which is compressing the duodenum from outside. So what are the causes of intrinsic? Intrinsic causes are either there is a duodenal atresia or a stenosis of the lumen, or there is a web that causes double bubble sign or duodenal obstruction. What are the extrinsic causes? During the development, if there is a annular pancreas or a malrotation with midgut volvulus or Ladd's band, these will cause duodenal atresia. Okay, remember duodenal atresia is mainly seen in the infants. Okay, so it has an intrinsic cause and an extrinsic cause. Intrinsic, inside the lumen, so there can be atresia, stenosis, or a web formation. Extrinsic, it can be because of the annular pancreas, because the pancreas, in annular pancreas, what happens is the whole of the pancreas is compressing the duodenum. Okay, and in cases of malrotation with midgut volvulus or Ladd's band is there, then you will see double bubble sign. Okay, now coming to another X-ray. This is an X-ray. See, everything is written here. X-ray abdomen, erect, AP view. Okay, this is how do you say this is in the exam is this is an X-ray of abdomen, AP view, erect posture, showing what you can see here is Can you appreciate there is a Riles tube? The radio opaque line coming from the thorax into the abdomen. Okay, and here a bulb, Riles tube bulb radio opaque line you can see. Okay, so there is some disease where Riles tube has been put, and then what we'll search for is, you can see dilated bowel loops. Okay, you can see dilated bowel loops, and then what you see is there is air above and a fluid below. So there are multiple air fluid levels. Okay, more than two air fluid levels is significant, suggesting an obstruction. Okay, then now you know there is multiple air fluid levels in the abdomen, that is suggesting it to be intestinal obstruction. Now further you need to know is whether it is a small bowel obstruction or a large bowel obstruction. So to differentiate between a small bowel and a large bowel obstruction, there are 2-3 points. One is the small bowel will be more placed centrally. Okay, and the large bowel obstruction will be more placed laterally. That is one point. Another point is, in the jejunum what you see is, in the mucosa there are volvi conniventes. Okay, so these volvi conniventes is like a spiral. Have you seen a spiral binding books? So the circular books are there, spiral things. So volvi conniventes, what will happen is, you will see like a spiral thing here with a completely circle. Okay, so that suggests this is jejunum. Okay, and when you see the ileum, what is there is, there is no specific markings there. They are just placed like this. Here can you see any spiral binding kind of thing? No. Okay, but here you can appreciate it. So these are jejunal loops, and this is a ileal loop. Ileal loop is called structureless, that is why. So this is volvi conniventes. Okay, this is structureless ileum. So you can see dilated loops with multiple air fluid levels in the jejunum and in the ileum. So most probably this is an obstruction of the distal ileum. So this is a small bowel obstruction. That is how you come to the conclusion. Why is because whenever there is an obstruction in the bowel, the distal to the obstruction is a collapsed loop, and proximal to the obstruction is a dilated loop. So in the dilated loop, you will have air fluid levels, and the obstructed or the distal loop will not be visible. So this is a case of a small bowel obstruction. Okay, again the same thing. What you see here is the Riles tube is there, and then most of the bowel are, there is no volvi conniventes here. But what you see is the structureless ileum. So this is again a case of a small bowel obstruction. So because of the obstruction, and when you take a erect X-ray, what will happen is the fluid tends to stay down, and then the air tends to go up. So you will get a characteristic pattern of air fluid level. See, this is a air fluid level, this is again a air fluid level, this is again a air fluid level. Okay, so that suggests towards a small bowel obstruction. Again the same thing, the multiple in a more zoomed view is, again what you see is air up, fluid below, and there is a level. This is again a air fluid levels. So now, what are the causes of small bowel obstruction? Most commonly it is the post surgical adhesions. Let's say, for example, a patient has undergone a laparotomy for some any reason. So in those cases, they can have acute obstruction, which is within the 4 weeks of surgery, or a chronic obstruction. It can occur anytime later part of life. Okay. And in cases of incarcerated groin hernia, in the groin hernia, if it is obstructed or incarcerated, what will happen is, because the small bowel has gone into the hernial sac and there is obstruction, so there will be a proximal dilated loop and a distal non-dilated loop. Okay. Other etiology are malignant tumors, hernia, inflammatory bowel disease, volvulus, and miscellaneous causes like hypokalemia or uremia. Uh, they can cause small bowel obstruction, or in pediatric patients, congenital atresia, pyloric stenosis. Okay. How these patients present with? Yes, because there is obstruction. So what will be the causes? Because of the peristaltic, forced peristaltic, there will be colicky pain. Okay. And then you have vomiting, and because there is obstruction, so nothing is going down, so obstipation would be there. What is obstipation? There is constipation, as well as flatus also won't go. So pain abdomen, colicky pain abdomen, vomiting, and obstipation, these are the features of small bowel obstruction. So what do you do with small bowel obstruction? If it is a post-surgical adhesion, initially you will try to treat the patient conservatively with nilper oral, put a Rice tube, IV fluids. Okay. If it is not subsiding, then these you have to open up the case and see where is the adhesion, and you have to do a adhesiolysis. If it is because of the obstruction, obstructed hernia or a incalcinated hernia, then you have to do a emergency exploration. See the hernial sac. If the bowel is gangrenous, you have to resect the bowel and do resection anastomosis and do a herniorrhaphy. Or if bowel is healthy, then you push the bowel inside the abdomen and do a herniorrhaphy. Okay. Volvulus has to be dealt accordingly. I'll come to the volvulus now. So now what you see is an X-ray showing a dilated loop. Okay. Can you appreciate the dilated, hugely dilated loop here, or here also? A dilated loop with air fluid levels and a whitish band like thing inside. Okay. When you see these kind of X-ray, this corresponds to a coffee bean sign. What you see here, a dilated loop and a arrow, that is the mesentery, pointing towards the right upper quadrant. Okay. So something like a coffee bean. So that is why it is called a coffee bean sign. Okay. These are typical features of a sigmoid volvulus. So what do you mean by sigmoid volvulus? Is sigmoid gets rotated on its own axis. Okay. Because of, and this is an intraoperative picture where you see the same patient. When you open up, either you can see a sigmoid without gangrene, or sometimes you might see a sigmoid, sorry, with gangrene. Okay. So in abdominal film, you will see coffee bean sign. Okay. That is sigmoid volvulus. In the when the bowel points towards the right upper quadrant. Cecal volvulus is very rare. You will see in the bowel pointing towards the left upper quadrant. Okay. Why does sigmoid volvulus happens is because of the redundant colon with a narrow mesenteric attachment. The sigmoid twists, rotates anticlockwise along its axis. Okay. And so the predisposing factors are chronic constipation, high fiber diet, or a roundworm infestation, or a megacolon. Okay. So when there is a counterclockwise rotation, it can either rotate up to a 180 degree or up to a 540 degree. When it is rotating up to a 180 degree, you will see only a luminal obstruction without gangrene. When it rotates more than 360 degree, so there is venous occlusion and gangrene and perforation. Like you saw in this probably might have not rotated a 360 degree, so the sigmoid is non-gangrenous and healthy. This probably would have rotated a more than a 360 degree, so there is venous occlusion and there is gangrene. Okay, so in these cases, what are the options you have? Oh, sorry, the signs and symptoms, how do they present? Either they present in an acute phase or a chronic phase. Okay, in acute phase, there will be acute distension, colicky pain, and failure to pass flatus or stool. There will be history of a constipation. Okay, and vomiting in a large bowel obstruction becomes a late sign. So vomiting in large bowel obstruction is rare. Okay, in chronic phases, sometimes the patient presents with chronic constipation with abdominal distension followed by derotation on its own. These are mainly elderly people, comes with history of chronic constipation, abdominal distension, and then suddenly passing of flatus and stool and sudden decrease in the abdominal distension. These kind of history the chronic patients will present with. In acute cases, it is acute distension, colicky pain, and obstipation will be there in these cases. So distension may compromise respiratory and cardiac functions. So this is also an emergency surgical condition. Okay, so differential diagnosis would be a sigmoid colon carcinoma. Carcinoma can also present as an obstruction, or there can be a pseudo obstruction, colonic ischemia, perforation, and sepsis. Okay, so what do you do with these patients is initially always preoperative preparation and then plan for decompression. Decompression can be either laparoscopically you can do or a colonoscopically you do. Decompression is basically to tide over the crisis. If there is no gangrene, then you can just do a colonoscopy and derotate and decompress it, and later on you can take up the patient electively for surgery. Or if there is a gangrene, then you never try. Gangrene is a contraindication for colonoscopy. In those cases, you do either a directly do a laparotomy, a bowel resection, and end-to-end anastomosis, or do a Hartmann's procedure. That is, you resect the part, leave the distal part in the abdomen, and the proximal part you bring out as a colostomy. Okay, so you have two options. That is colonoscopic decompression or a laparotomy. Decompression you will do only when you don't think there is any gangrene or perforation. Okay, so in those cases you can do a colonoscopy and derotate it. But whenever you suspect it to be gangrenous or perforation is there, then you will do a laparotomy and do a bowel resection and end-to-end anastomosis, or you do a Hartmann's procedure in where what you do is resect the gangrenous segment, put the distal segment inside the abdomen, and bring out the proximal segment as a colostomy. Okay. Now what you see here is radio opaque densities in the abdomen. Okay, multiple radio opaque densities in the abdomen. Okay, basically it is not, the full view is not there, so it is very difficult to say, but this is in the right side, just lateral to the vertebra. Okay, so in the right side lateral to the vertebra, radio opaque stones are seen. That means either it is a gallstone or a renal stone. Uh, but the position here suggests towards a gallstone. If somebody asks you, how do you confirm it is a gallstone, then you will say, I'll take a lateral X-ray. Okay, when you take a lateral film, if it is gallstone, it will be away from the vertebra, anterior to the vertebra. If it is a renal stone, it will be superimposed to the vertebra. Okay, so this is a radio opaque gallstones. And how many percentage of gallstones are radio opaque? It is very less, that is up to 10%. So X-ray abdomen is not an investigation of choice for gallstone. They are basically usually not seen on X-ray. Only 10% of gallstone will have calcium embedded in it so that it is visible on X-ray. Otherwise, most of the gallstones are not seen on X-ray. Okay, so the investigation of choice in gallstone is USG abdomen, not X-ray. Okay, now coming to what you see here is multiple calcification seen, which is going from the right side to the left side. Okay, from the right side to the left side at the level of L2. Okay, so this is a feature characteristic of chronic calcific pancreatitis. This is the area of the pancreas. Okay, okay. In the area of the pancreas, when you see calcification, that suggests it is a case of a chronic calcific pancreatitis. Okay, and these patients usually presents with chronic pain in the abdomen and bulky, white, sticky, greasy, foul-smelling stool or diarrhea that is called steatorrhea, weight loss, and because the pancreas is involved, so there can be fat-soluble vitamin deficiency causing skin peeling and night blindness, bone pain and fractures due to vitamin D deficiency, easy bruising due to vitamin K deficiency. And when the endocrine function of the pancreas is involved, then these patients will have diabetes. Okay, so these patients will basically present with chronic pain abdomen, steatorrhea, weight loss, then features of vitamin A, D, K deficiency, and diabetes. And in these cases, the investigation of choice is a CT scan of the abdomen. Okay, and what is the treatment? Basically, you should know is lateral pancreatico-duodenectomy, that is called LPJ. L. Now, what you see here, how do you describe this one is, this is a plain X-ray abdomen PA view. What do you see? Is there any obstructive features? No, these are only small gas-filled bowels. Okay, okay. So there is no air fluid level, so there is no obstruction. Now come down, bone is okay, but what you see here is a radio opaque, multiple radio opaque densities. So this is a case of a right lower ureteric calculus. Okay, right lower ureteric calculus. So these ureteric calculus can usually originates in the kidney, and it can get stuck in the areas of the ureter where it is narrow, that is at the pelviureteric junction or in the upper ureter or in the lower ureter or at the ureter and the bladder junction, that is UV junction. Okay, majority of them are calcium oxalate stones. Okay, and when there is complete obstruction, they can cause hydronephrosis or hydroureter, and they can become infected. And then they present with colicky unilateral colicky pain. That is, if it is in this case, the patient will present with a right-sided colicky abdominal pain with hematuria, with or without urgency and increased frequency and micturition, and nausea and vomiting. The specific investigation for ureteric calculus is a non-contrast helical CT. Okay, ultrasound is done routinely as a routine investigation. Sometimes ultrasound might miss the stones, but the investigation of choice is non-contrast CT of the abdomen. Okay, IVP, it was done earlier, but with the advent of CT, IVP is no longer used. Okay, it is done mainly where there is no CT. KUB, that is X-ray of the kidney, ureter and bladder. You can do it, but sometimes you will miss it. What is the treatment is, most of the stones which are very small, that is less than 5 mm, will be treated conservatively with analgesic fluids and antiemetics and anticolic drugs. But sometimes when it is a larger stone, you will need a ESWL or a URS. That is, endoscopically you put the catheter into the through the urethra into the bladder and the ureter and remove it through Dormia basket or ureteric myotomy, and sometimes you need to do a ureterolithotomy. Okay. Now coming to another X-ray. This is also again a X-ray of the abdomen. There is no bowel, nothing is there. Okay. When you come to the pelvis, there is a radio opaque density in the bladder region. Okay. So this is a bladder calculus. Sometimes some examiners might ask you any other differential diagnosis for this. So a calcified lymph node or a fecalith might present like this as well. But most commonly you will first give a diagnosis of a there is a there is a density seen in the bladder region. So my diagnosis is a bladder calculus. If somebody asks you any other diagnosis, then you can say either it is a fecalith because it is in the region of the rectosigmoid region, or it can be a calcified lymph node. Okay. So now coming to the bladder calculus, it is usually seen in elderly people with frequent urinary infection, or if there is any foreign body, sometimes some suture material can act as a nidus for stone formation. Mostly they are formed in the bladder. Remember, ureteric stones are mainly formed in the kidney, and then they drop down, but urinary bladder stones are mostly formed in the bladder itself. And most stones in adults are formed of uric acids. Okay. And long standing untreated bladder stone can give rise to squamous cell carcinoma. So they will present with suprapubic pain, dysuria, hematuria. Okay. In men, they can present with a pain or discomfort in the penis, frequent urination because of the irritative nature of the bladder. Okay. Difficulty urination or interruption of urine flow, cloudy or abnormally dark colored urine. These are the symptoms the bladder calculus will have. And the types, what I said is, most commonly they are formed, originate in the bladder. So they are mostly secondary types. Okay. They usually associated with infection and mostly originate in the bladder, but primary stones may sometimes be there, which develop in a sterile urine, mostly originates in the kidney, and then they drop down into the bladder. So what are the diagnostic tool you have is a plain X-ray, what you saw right now, and then bladder ultrasound, CT scan, and you can do a cystoscopy to diagnose these cases. What are the treatment options you have is basically three, that is transurethral cystolitholopexy, percutaneous cystolitholopexy, and open suprapubic cystostomy. So basically what is you need to remove the stone. Either you crush the stone and remove it, or you can directly open and remove the stone as a whole. So and all these endoscopic methods is to crush the stone and remove it. That is, you go through the urethra and crush the stones and then remove the fragments. That is called transurethral cystolithoplexy. Lithoplexy is nothing but it means crushing. Okay, so when you go through the urethra, it is transurethral cystolitholopexy. When you go through percutaneously, that is through the skin, then it is called percutaneous cystolitholopexy. And you have another option, that is open suprapubic. In the suprapubic region, you open the bladder and remove the stone. That is called open suprapubic cystostomy. Now, what you see, this is an X-ray of the IVP, that is intravenous pyelogram. Okay, again, in the IVP, what you will see is the dilated pelvis, the ureter, and the bladder. Because with the advent of CT nowadays, it is not very commonly done, but yes, it is done in some cases. So what is a IVP? It is intravenous pyelogram. These are a series of X-rays are taken of the kidney and the collecting system, that is the ureter and the bladder. Okay, when you take series of X-ray, is you inject a iodine based dye, that is urographin, and once you inject it through the vein, and then you start taking series of X-ray at an interval of 0, 5, 10, 20, 30. Okay, so in that way you will get the films. So basically in IVP, most of the IVP you will there will be a time written. I don't see anything written in this one. Okay, most of the IVP, the timing will be written either 5, 10, 20, 15, and these contrast will be seen. So you can know that is IVP. The contraindication to IVP is either allergy, okay, allergy to the dye, and then CKD patient, diabetic patients, these pregnant patients, you don't do IVP. Other alternative to IVP is CT scan or MRI. Okay. Basically, IVP is done to evaluate the any abnormality of the urinary system, to evaluate causes with hematuria or pain in the side or lower back. Sorry, anything in the urinary tract. Okay, kidney stone, enlarged prostate, tumors in the kidney ureter or urinary bladder. Okay, or any congenital anomalies of the urinary tract. Now this is a X-ray. See, this is written here. This is a X-ray KUB. What do you see? That is kidney, ureter, and bladder. So when it is KUB written, so you will focus only about the kidney, ureter, and the bladder. So what you see is there is a in the pelvic calyceal system. What you see is a opaque area. Okay, so these are staghorn calculus. Okay, so this is the pelvis. The calculus is totally in the pelvis and going into the calyceal system of the left kidney. So these are called staghorn calculus. Okay, I won't go into the staghorn calculus or the strobite stones. So in these cases, the treatment is basically surgical, because these are large stones. Okay, either you do a open surgery, but nowadays more and more it is the percutaneous nephrolithotomy is most commonly done for pelvic stones. Okay, and shockwave lithotripsy. You should know the surgical management, that is open surgery, percutaneous nephrolithotomy, and shockwave lithotripsy. Okay, can you appreciate the Stagon calculus here?
Yes, sir.
Okay. Now coming to the barium. Okay, what I have done is mainly what will be there in the exam. I'm just going through them. Okay, these are the things basically will be asked in your MBBS exam. Now coming to a case of a barium meal. Okay, a patient is given barium, and then the series of X-rays, like in IVP here also, that is urographing through venous channel it is given. Now this is the patient is asked to drink. Okay, so this is a barium swallow. When the patient is swallowing, you take an X-ray of the neck and the chest, so you will see the esophagus. Once the patient already taken barium, if you take an X-ray of the abdomen, that is called barium meal. Okay, once the barium meal the patient already have taken 2 to 3 hours, after that you take an X-ray, so that is called barium meal follow through. Okay, and then if you give it the barium as a enema, then it is called barium enema. So for the large bowel it is the barium enema, for the esophagus it is the barium swallow, for the stomach it is the barium meal. Okay, for the small intestine it is the barium meal follow through. This is the general rule for barium X-ray. So this is a barium swallow showing, what do you see? There is a dilated part here, there is a narrow part here, and then the normal part here. Okay, so there is a narrow esophagus in the distal part of the esophagus with a shouldering above. Okay, so this is basically a feature of a carcinoma esophagus. Okay, so the same, what you saw is a dilated, that is above the cancer there is dilatation, there is a obstruction, so there is a narrow part, and then a normal esophagus. Okay, same thing, see, there is a dilated normal esophagus above, there is a malignant part here, so there is a narrow part, and then you have a normal esophagus there. So this is a feature suggestive of a carcinoma esophagus. Now coming to the barium meal. Okay, so what you see in here is the stomach. This is the greater curvature of the stomach, this is the lesser curvature of the stomach, and then there is abrupt cut off, but the barium is going into the C-shaped duodenum. So there is some obstruction over here at the pylorus or the antrum. So this is suggestive of a carcinoma stomach. Okay, barium meal showing suggestive of carcinoma stomach. This just for your to know about barium enema. So barium enema, basically what you see, there is some instrument which is pushing the enema into the large bowel. Okay, so basically you can do a barium enema or a barium enema double contrast. So in double contrast, what you do is you push barium as well as gas for a better delineation of the large intestine. Okay, so that is why you see like this. Okay, so this is basically a normal X-ray, barium enema, double contrast of a large intestine. There is no obstruction. It is nicely, the barium is going up to the ileocecal junction. Okay, so this is a case of a barium enema double contrast. Okay, so that's all for X-ray. I think you have a class at 3 o'clock. Okay. Anything extra you want to see? I'll just quickly go through the X-rays again. Okay. So this is a case of a holoviscous perforation. This is a case of a pneumothorax. This is a double bubble sign seen in duodenal obstruction. This is air fluid, multiple air fluid level in small bowel obstruction. Again, multiple air fluid level. Okay. This is a coffee bean shaped or dilated intestine is seen in sigmoid volvulus. This is radio opaque gallstones. This is multiple calcification suggesting a chronic calcific pancreatitis. This is a case of a right ureteric calculus. This is a bladder stone or bladder vesicle calculus. This is a normal IVP, that is intravenous pyelogram. Okay. This is a case of a staghorn calculus on the left side. This is a carcinoma esophagus, that is X-ray of a barium swallow. Okay. This is a barium meal showing carcinoma stomach. Okay. And this is a double barium enema double contrast. Okay, any doubt? Any doubt?
No, sir.
Okay. Thank you. All the best for your exam.
Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you, sir.